Good evening, everyone. This is Shreyan from IJCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Ramamurthy Bingi. Sir is MBBS MD Medicine, DM Cardiology, Interventional Cardiologist at Bingi Heart Care and Fertility Center, Bangalore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is stress and stunt myocardium, a real case of Takotsubo cardiomyopathy. Now, without any further delay, let me welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Ankana. Thank you very much for having invited me for this platform. I hope I am quite audible on that side. Okay.
Yes.
I was requested to this time a little bit going away from the usual didactic lectures on the subjects of sharing interesting cases which I came across in my day-to-day cardiology practice. Of course, this sort of a discussions always will raise a lot of questions, possibilities of various differential diagnosis. And one of the rare cases which you see like this probably adds up to your so-called clinical experience. With these few introductory words, I'll be sharing two interesting cardiac cases, which are both of them are related to this. As Ankana was saying, these are cases of what we call the Takotsubo syndrome, or simply put it as what we call as stress cardiomyopathy syndromes. Here I am presenting the two cases. One of the first case, which is a 38-year female patient. She didn't have any known risk factors except on the slightly on the overweight size. And to make it really interesting to you, let me tell how the story evolved. This lady was traveling from Delhi to Bangalore in a flight, and she was in a hurry coming to Bangalore because she heard the demise of her beloved father. She couldn't take it so easily. She was intensely stressed out emotionally, and she developed a sort of a chest pain, which was typically looking like an anginal pain, lasted more than 20 minutes. By the time she got down in the airport, the pain was still persistent. She made out that something is not good, and that is how she reached our hospital. When she reached in our casualty, her cardiac examination was normal. Her pulse rate was around 90 or so. Blood pressure was normal. Jugular venous pulse was normal. Cardiac sounds were normal. Uh, there was overall cardiac examination was normal. And with this sort of a clinical presentation, any patient presenting with more than 20 minutes of chest pain, we have to consider the common causes always first. We consider it as an possible acute coronary syndrome and maybe myocardial infarction or an prolonged angina, which we have to do with the further investigations, including ECG and our blood test. Equally, because she was traveling in the flight, we also considered possible pulmonary embolism. And we requested for emergency angiogram. We did an ECG, we did an echocardiogram. And of course, let me tell later on subsequently what are the other investigations which showed, including coronary angiogram to document the coronary arteries. And with this sort of an basic level investigation, we went ahead and the troponin T came off after about 2 hours of the patient presentation. It was negative. And this is the ECG. If you really look at the ECG, the ECG changes are heart rate is relatively well controlled. There's a T inversion in 1, 2, 3 AVL and F, almost like a global ECG changes, except in V1, you have an T inversions starting from V2 to V6, But as we go into the lateral leads from V3 onwards to V6, the T waves are much more deep and suggestive of a possible subendocardial ischemia. In AVR, T wave is upright. And overall, if you really look at it, looks as if the QT interval is slightly prolonged. Concentrate on V1. In V1, you find an P wave is biphasic with the negative component being very prominent. This says only that it is a possibly a sort of an subendocardial ischemia and or infarction. This was an echocardiogram. I'm sorry for the poor echo window. As we concentrate in the short axis, you really look at the anterior septal and anterior wall is relatively hypokinetic. There is an dense shadow seen also into the attached to the anterior wall. Already a clot formation has taken place. This is another V which you see in both the systole and diastole. There was a regional wall motion abnormality in the anterior area. This is in the long axis V. We make out in the mid septal the same phenomena. And the overall LV dimensions appear to be slightly more, but the wall motion abnormality is better seen in a long axis wave in the mid septal area. So we asked for an further investigations. Since the ECG was very provocative and the enzymes were not very helpful, young woman, prolonged angina, because we are all now geared up to do the angiograms and probably primary angioplasties and all that. Because she presented with the time, we went ahead and asked for an angiogram. Now, before we asked for angiogram, we said that since the patient was not having many risk factors, this is the first episode while traveling. So we need to hit the bull both with one single arrow by looking at not only the coronaries, possibly excluding the pulmonary embolism also. This is the CT angiogram. As you see, the main pulmonary artery and the branches appear to be overall normal. In the third panel, you can see the LAD, and in the subsequent views, diagonal branches, and also the RCA. All of them were normal. Now, this was the in conclusion, a patient having an prolonged ischemic pain, but the coronary is being normal with a regional wall motion abnormality, negative proponents. So the differential diagnoses are many, but anyway, we have to keep it in mind what we call as a stress cardiomyopathy. One. Second thing is it might have been a coronary spasm, or it might have been a thrombolized coronary artery, and the like. So many things we keep it in mind. This is a open sort of a discussion which we can all do. Okay, and subsequently I will try to highlight how it is different from the classical variety of stress cardiomyopathy. Let me go to the second case. Here, this patient is slightly on the obese side. He was already a diagnosed hypertension. And again, he had a very intense emotional stress to kindle the interest among you, let me tell this person. So, daughter had a breakup, marriage breakup, and it made him so much emotionally stressed out. He came with some sort of vague chest discomfort. And of course, when we thought that this may be an acute coronary syndrome, we asked for an ECG echo and tried to look at the course of the patient. Here, as you see in this ECG, there's nothing extraordinary. You make out overall, ECG says there may be a borderline left ventricular hypertrophy, but there are some T inversions starting from V1 to V6. They are more flattened out in V4 to V6, but the T inversions may be seen in V4, V1 to V3. Other than that, we make out that. Sorry for the interruption, there is a phone call. As you make out, these are all the non-specific T changes in a patient who presents with chest pain. He's a 63-year-old male patient. Troponin T was mildly positive. It was not by looking at the chest pain and ECG changes. Okay, but it doesn't really look like a major MI that is happening at that moment. We did an echocardiogram. In the echocardiogram, here again, the mid-septal and the distal septal area, there was an thinning and hypokinesia, but which is much more evident in the fourth chamber view. You make out the distal septal, septoapical and apical area. There is a significant amount of a little bit of, if you really look at it, maybe some sort of a ballooning or aneurysmal type of a pattern. This was an angiogram to show the left main coronary artery is normal, left anterior descending artery is normal, circumflex artery is normal. This is another view to show that the coronaries are normal. This is another view. So this is the right coronary artery in different angles. So overall normal. We use the same catheter and try to look at the left ventricular angiogram. You really concentrate on that. The angiogram, in spite of the repeated ectopic piece which you saw in the picture, you make out that there is a sort of a ballooning involving the apical area, apicoseptal area of the ventricle. Overall, LV doesn't appear to be so much dilated, or suggesting a typically this case may be a sort of a stress cardiomyopathy. You can make out that. Now, highlights of the case is basically we should make out that there was an intense emotional stress. You can say that this sort of emotional stress is also seen in even in acute myocardial infarction and acute coronary syndrome also. But what is important is we should remember it mimics an acute coronary syndrome, and thus an emotional stress is it doesn't exclude or it doesn't include an acute coronary syndrome. What we made out was in both the cases, both the first case and the second case, the ECGs were not very typical. And even including an echo, except in the second case, you made out a little bit of a ballooning. Overall, it was a typical echo. The enzymes were mildly elevated. And the most important thing is epicardial coronaries were normal. So these constitute both of them probably what we call as a Takotsubo syndrome, also known as broken heart syndrome, stress cardiomyopathy, or stress syndrome, whatever it is. These are all diagnoses which are basically made out by exclusion. Now, in this stress syndrome, stress cardiomyopathy, what is happening is there is a myocardial injury, but overall there is no infarction. Enzymes may be elevated. Enzymes are elevated even in unstable angina syndrome also. This is basically related to the intense catecholamine surges with a myocardial injury because of emotional stress. And there is always a history of a preceding intense emotional stress, but this stress may be even in physical, which I will tell you in the subsequent slide. The picture is more like a combination of an acute coronary syndrome. Many of those patients will also have manifestations of heart failure. And the funny thing is, this cardiomyopathy is reversible. It's a transient LV dysfunction. This we have observed over a period of about 2 to 3 weeks time, maximum another 3 to 4 weeks time. It becomes completely normalized. So sometimes the diagnosis is retrospective. After having recognized that the LV function has completely recovered, we make a diagnosis of stress cardiomyopathy. ECG typically shows ST elevation, but there can be just an STT changes or only T changes as we saw. ECG is another characteristic is that in a typical MI, what happens is if you find an ST elevation in a group of leads, like anterior leads, there will be some reciprocal changes in the inferior leads in the form of ST depression. These sort of changes will not be seen in a stress cardiomyopathy. And when you do an echocardiogram, the highlighting point will be there will be wall motion abnormality, but it doesn't fit into a particular segment, an LAD distal territory or an RCA territory and the like. It may extend beyond the one single territory. This is a very characteristic picture of an stress cardiomyopathy. And the prognosis and complications don't think they are in any way different from an acute coronary syndrome. They do develop arrhythmias, they can be sudden death. Prognosis is sometimes bad, they can go into heart failure and repeated ventricular tachycardia and the things. So far, the treatment has been empirical. And only one plus point is in these cases, the recovery is almost complete. And the literature has shown the stress cardiomyopathy can sometimes be going on recurrent in nature. There have been a lot of scores and other things have come, which I'm not going to talk about. The points are that atypical varieties of stress cardiomyopathy are as frequent as typical. What we have been reading in the literature and the textbooks is a typical cardiomyopathy. Young woman, intense stress, having an ST changes and T changes with a typical ballooning which is seen in an angiogram, but the same sort of picture can be seen by a diligent echocardiography also. And of course, the diagnosis is by exclusion of acute coronary syndrome. In these two cases, the clinical pictures were atypical varieties, not a typical. Coronary angiogram is very important. We should do them, and it is to exclude the coronary artery disease. Earlier studies showed contrast coronary angiogram should be done, but in some selected cases, young people, young women, as in the first case, in 25s to 30s without having many major risk factors. And particularly if you want to exclude other entities like pulmonary embolism, we can request for a CT angiogram scanning, which can also look for both the pulmonary arteries as well as the coronary arteries. The largest number appear to be in the one of the latest literature as far as we are observing it are seen in most of the time in ICU and post-operative setups. Of course, clinical diagnosis, index of suspicion is needed, and accordingly, people have divided them into primary and secondary, a typical case and a atypical case, and morphological criteria are variable. The Mayo Clinic people have introduced some criteria, and the different point which I would like to emphasize is that typical Takotsubo are not seen. There are more different precipitating causes, more atypical ECGs, more echo different features, and though some of the ballooning sign, nipple sign have been talked about, but we do see more of the time slight wall motion abnormalities. Women in the postmenopausal age above the 55 years, more common it was one of the study, but it has also been seen in men who have associated psychiatric disorders and emotional disorders. And this particular study also emphasized in the post-operative setup, post-ICU setup, and post-shock status setup, sudden deterioration of the patient, one should always think of a possible stress cardiomyopathy. We have to have a high index of suspicion and diagnose and treat them. Imaging can be either a conventional angiogram, contrast angiogram, or a CT angiogram. Of course, there are differential diagnoses as they brought out: acute coronary syndrome, transient coronary spasm, recanalized coronary arteries, pheochromocytoma, carditis, cardiomyopathy should also be considered in mind. And in this particular, this is one of the slide which I have taken from the literature, different categories of wall motion abnormalities that were seen in an stress cardiomyopathy have been documented. Unfortunately, nowadays in the regular evaluation, unless a high index of suspicion is there, we don't do the LV angiogram. We most of the time depend on the probably echocardiography. But once in a while, if there is a very high index of suspicion, we should be able to do the coronary LV angiogram also. Now, summarizing both the cases, there was an intense emotional stress. Age group was variable. One was a young female, 30s, another person was in the 60s. It is as common in men as women. ST elevation is seen in typical stages, but in atypical cases are more in number, and there you may see a gamut of ECG changes. ST depression, if you are concentrate on the reciprocal changes, if you want to really make a diagnosis of an acute MI pattern like picture. Troponins may be elevated, majority of the time they're normal. Wall motion abnormality is not very helpful, except you have to see them in other ECG changes, or you see them extensively in other than one single territory. Any imaging, either a contrast or a CT, can be used. Shortcomings are that in our cases, we did think clinically of pheochromocytoma, but we didn't do the detailed examination. And in some cases, we may have to even try to look at cardiac MRI to exclude some of the carditis syndromes. Though the typical cases are rare, atypical cases are frequent. Physical stress is as important as emotional stress. The one of the review which I was going through there, they have mentioned the stress cardiomyopathy is as much frequent in famines, wars, other than the ICU setup and post-operative setups. And in the recent COVID epidemic, there have been quite a large number of stress cardiomyopathies also, which have gone underrepresented in our setups. The echo picture may be varying. Diagnosis needs, of course, exclusion of common diseases like acute coronary syndromes. In some selected cases, you may have to go for evaluation of pheochromocytoma, coronary spasm, acute carditis, and the like. Acute prognosis is as bad. Don't think it is a very benign thing because the coronaries are normal. Long-term prognosis is also bad in that the recurrences are possible. Indeed, as the people used to call it as, is a broken heart or a broken heart syndrome. And these two interesting cases I made out to bring it to you because in these two cases, there was a need for high index of clinical suspicion. These two cases, there was a low probability of acute coronary syndrome. Uh, in one of the case, we did a CT, another case, we did a conversion angiogram. You may ask whether there was a minimal coronary artery disease maybe there, and then there is a clot might have dissolved and washed off. We don't know. This may be a recanalized. It may be a transient coronary spasm. There are some entities we know that AMI with normal coronaries and all that. Have you excluded them? This is only the temporal pattern in which the cases are presenting and the way they progress and the way they recover within about 2 to 3 weeks and the way the wall motion abnormalities more or less completely disappear. That is how we make a diagnosis of Takotsubo syndromes. Diagnosis depends most on clinical features. Absent risk factors are equally important, and correlation. Correlation with ECG, ECG with echo, echo with the enzymes with the coronary angiogram are important in making a diagnosis. In essence, it is a diagnosis by exclusion. These two interesting cases are in order to highlight that one should not go only by bookish knowledge of finding out an ST elevation, ballooning apex, and young women with intense stress. It can be seen even in men also with emotional stress. In both the cases, we did keep it in mind possibility of this syndrome because the coronaries were normal and at the same time there was a history of a very intense emotional stress. Thank you for your patient hearing. Any other questions or comments, I'll be able to take it. Karan?
Thank you, sir. Thank you so much for this wonderful presentation. We do have some question if you like to take that up. So, sir, the first question is, how does Takotsubo cardiomyopathy affect left verticular function, and why does it typically resolve?
This is basically an sort of an maybe it's some we can say that is a sort of a stunning phenomena. This is because of the catecholamines. So the catecholamines, they do make the myocardial dysfunction, and once that emotional episode is gone, that wall motion abnormalities they do improve, LV function improves, and that is how the patients improve.
Next up, sir, what supportive measures should be taken for patient with hemodynamic instability or cardiogenic shock?
In these patients, of course, the management is the same as for an acute coronary syndrome. And we do manage with an antiplatelet drugs. There is no harm if you have already added a statin. Maybe you have to use the beta blockers and maybe unloading agents depending on the blood pressure and overall LV function.
So there's one last question. How do we counsel patient regarding stress management and lifestyle modification to reduce future episode?
A very interesting question. The things are not ending by just making a diagnosis and just sending off the patient. And we should be able to counsel them to see that they control their emotions by, avoiding the situations. And if they cannot avoid the situations, at least doing some biofeedback exercises like, yoga or meditation and the like. But whether the same intense emotions will go on repeating in that particular patient is difficult to say that. As minor categories of anxieties and emotions will be able to produce the same sort of a problem. I do not have an answer for that.
Thank you so much, sir, for answering all our questions. Before concluding, sir, any take-home message from your end?
Oh, thank you very much. I think the so-called spectrum of ischemic heart disease is a very interesting one as we have moved from the coronary obstructive disease to the level of coronary reserve problems, small vessel problems. We have also made out some entities like coronary spasm. We have made out some entities like coronary spasm superimposed on the minor atherosclerotic lesions. We have also got a spectrum at the other end of the spectrum, ischemic heart disease with the normal coronaries, um, diffusion issues, and this is one more, what we call as stress cardiomyopathy. After all, normal coronaries, but there is a definitely ventricular myocardium is affected. But fortunately, this is the reversible phenomena in majority of.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's